Ladies and gentlemen.
Thank you for everyone who bought tickets and came to Carol Swain last week. That was amazing. I thought she was terrific. And you know, yeah, she was great. Thank you to Riley Shia, who led our group. The Rileys over here who led our group. And believe it or not, 2 days after we finished on Wednesday night, and then Friday, Riley's on the phone with me talking about November and September, October, and November. We're already putting together the Virginia Forum speakers for this fall, which we just got to sign the contracts and then we can announce them so you can pre-buy tickets for September, October, and November. I think you're going to be really interested in the people that we're this close to closing on back at the Glen Allen Cultural Arts Center. So thank you, Riley, for all the work you're doing for that. And we'll make that announcement very quick. And then in June, we are coming here on the 26th, back to Park Lane Tavern, and Dr. Ann McLean is going to be here because, you know, when I have her on the radio, we always talk about art. She's a PhD from the University of Virginia on art history, and she will be here to talk about the statues that were removed in Richmond, where they are, and believe it or not, I don't want to spoil it, she's seen them up close and what the condition is now and the deterioration and the abuse of this world-class art that Richmond was known for so long. So Dr. McLean, I mean, I don't want her to go to jail or anything, but she is going to show you behind the scenes some pictures and video that no one else has seen June 26th. So put that down. I kind of have this feeling that it's going to be packed on June 26th, and goodness knows we might have some cops here because she has had to talk to some people and get some behind the scenes, because you know they don't want everybody to see this. And it's like Nightline on ABC back in the day with Dr. Ann McLean on June 26th. And then in July, we won't have a formal meeting, but keep your eyes open because we'll be sending you the email about our Patriot Party. So we want you to invite your family and bring grandkids and anybody who's out of school. The goal here is to make this fun and to celebrate America, not denigrate America, celebrate America. It'll be after the 4th of July, and try to grow our numbers and get people interested in the projects that we've got going on in the fall. Then we're going to take August off, and then we will hit the ground running in September. So that's the plan. And I really appreciate your support so far this year. So without any further ado, I want to welcome our speakers today. You've heard them on the radio talking about some of the really horrible legislation that has been proposed and some of the policies, forget legislation, some of the really horrible policies that have gone through at our hospitals and our universities that deal with medicine, with the insurance companies, pharmaceutical companies. I mean, there is a really nefarious movement to racialize everything in America today, and it's doing real damage. And these two men are strong enough, and I guess they've been in the business, like they've been doctors long enough where they don't have to worry about their status. Everybody knows they're great. They've got patients who love them. They have a reputation. But you know, a lot of people walk away at that point, and they are being brave to stand up against something that's really eating away at the fabric of America and making someone like you or me, who used to go to a doctor and you assumed they were well-trained and they cared about the patients and that they would do the right thing because it's the right thing for the patient. Now you gotta kind of second guess that. Are they trained? Do they know what they're doing? And are they motivated to help me, or are they making money for somebody else? And it's really a problem. So race, racism in medicine, debunking popular myths. Please welcome Dr. Kenneth Lipstock and Dr. Martin Caplan. You want to come sit up here? Terrific.
First, do I need the microphone, or you can hear me speaking?
Yeah.
Probably need it.
All right. Can you hear me? How's this? Testing. All right.
Yes.
All right, so I have my thoughts written down, so I'm going to read this. A little bit, lighting isn't the best, but I'll do the best I can. First, Thank you, John, Chairman of the Virginia Council. Thank you, Council officers, Ann McLean, and Bill Burr, and Riley for the Executive Directorship of the Forum, for inviting Dr. Caplan and myself for today's discussion on DEI in medicine. Make it louder.
Well, you have to kiss the mic.
Hello. Okay. So copies of this talk and references for points made in today's discussion are available upon request. You reach me at klipstock@gmail.com. Easy. So I'm Ken Lipstock, an eye surgeon practicing in Richmond for 40 years. It is both an honor and a profound responsibility to address you today on a subject that stands at the very heart of the medical profession. A new paradigm holds that doctors and doctors in training must seek to dismantle supposed systemic biases in healthcare. The principles of diversity, equity, and inclusion, DEI, are believed by many powerful organizations to be the panacea for all the disparities in healthcare outcomes. Racial health disparities are a persistent and tragic phenomenon. Trying to understand the root causes and potential solutions to these disparities is a noble cause. However, like many members of my profession, I'm concerned and skeptical that DEI is the answer. This skepticism wasn't born out of resistance to change, but out of a commitment to the scientific rigor that has always been the cornerstone of medical excellence. The more I engaged with these new policies, the more I felt compelled to question not just the efficacy, but the very implications of these sweeping changes on the core mission of medical training and practice. Our discussion today is not just an academic exercise, but a call to reflect deeply on the values we hold dear in the practice of medicine. The ethos of our profession has always been to heal, to reduce suffering, and to advance the well-being of all individuals without prejudice. But now, with all the evolving DEI directives, we're compelled to ask whether they enhance our ability to fulfill these timeless commitments, or if they are inadvertently leading us astray. I have concluded they most definitely have led us astray. As I was taught early on, doctor, first do no harm. We need to take a critical look at DEI in medicine. As I've mentioned, the integration of DEI into the medical education and practice has been met with a mixture of enthusiasm and skepticism. The skepticism arises not from a denial of the existence of disparities in healthcare, but from very serious concerns about the poor quality of research being done to substantiate the DEI healthcare narrative and the misinterpretation and exaggeration of its findings. We must also be cognizant of the enormous amount of funding being directed towards these studies, which means less funding for research and development for new treatments for many illnesses. Furthermore, we are very concerned about the DEI methods employed to address healthcare disparities and their long-term consequences on medical education and patient care. Consider this. The Association of American Medical Colleges, in its amicus brief for the Harvard affirmative action case, stated that if the assignment of high-risk black babies was given to black doctors, the survival rate would double. Justice Ketanji Brown repeated that claim in her arguments. The AAMC referenced a study that literally showed the difference in survival of high-risk newborns was a minuscule 99.6% versus 99.7%, or a 0.12% difference. So 1/10 of 1% is a far cry from 200%, yet they said that. Furthermore, the study did not control for the fact that very, very high-risk newborns are referred to white doctors more because there are more white neonatologists than black neonatologists that care for these very high-risk infants. He's my partner. The AAMC and Justice Brown also went astray at those hearings when they claimed that black doctors treat the pain of black patients better than white doctors. We've all heard that. The AMC referred to 4 studies they claimed proved this. However, these studies only documented the fact that pain management was more difficult in black patients. They never even addressed whether the pain was managed better by black or white doctors. It's unconscionable how such a powerful organization at such high-risk hearings could get the facts so wrong. And the AMC is the organization that sets the standards for every medical school in the U.S. There's been an alarming shift in focus in medical education. Traditionally, medical education has been deeply rooted in the sciences such as biology, chemistry, and physiology. These disciplines form the bedrock upon which clinical knowledge and patient care practices are built. However, in recent years, there has been a significant shift towards incorporating social sciences and identity politics into the curriculum. This shift was prompted by the growing belief that many health disparities seen across different populations are primarily due to systemic biases within the healthcare system and society at large. While it is undeniable that social factors play a role in health outcomes, the degree to which these factors should influence medical training and practice remains a contentious issue. The hypothesis that introducing a curriculum heavily focused on DEI will lead to better healthcare outcomes is largely unproven. This approach presupposes that by understanding social issues, future physicians will be better equipped to treat patients from diverse backgrounds. However, it also risks diluting the emphasis on hard sciences, which are essential for diagnosing and treating diseases. For example, an entire first-year course at the UCLA School of Medicine devoted to, quote, structural racism in health. Health equity. Teaches that, quote, this is a course, real course, quote, weight loss is a hopeless endeavor and that fat phobia is medicine status quo, unquote. It also calls upon, quote, moving beyond capitalism for our health, unquote. The valuable time spent learning this propaganda is time that should have been spent on the basics of anatomy and physiology. So let's look at bias and its effect on healthcare outcomes. We're told to believe that the disparities in healthcare are primarily the result of unconscious biases and systemic discrimination. To counteract these biases, medical schools and healthcare institutions have begun to implement training programs aimed at making healthcare professionals more aware of their unconscious biases and encouraging practices that are more inclusive. Exhibit A, SB 35. This bill mandated implicit bias training for ongoing recertifications for Virginia's MDs. Thank you, Governor Youngkin, for vetoing this bill. The effectiveness of such bias training programs in changing actual healthcare outcomes is still under debate. Studies have shown mixed results, with some indicating minor and short-lived improvements in awareness and attitudes, while others see no significant changes in behavior or patient care outcomes. After all, a mainstay of these bias training courses is the implicit assessment test, which is supposed to determine if you are unconsciously racist. In 2007, a European psychology study used it to conclude that 68% of whites are racists. And ever since then, the claim has been amplified by the media and has entered the popular culture. But this popular test has been proven to be completely unreliable. The same person taking the test multiple times will get multiple different answers. And it also fails at predicting who will actually commit racist acts, with an astounding 96% false positive rate. So implicit bias training programs, with their focus on identity and group characteristics, can sometimes lead to a form of stereotyping that can be counterproductive. It can cause divisiveness and mistrust among staff, and can contribute to a change where patients are seen more as representatives of groups rather than as individuals with unique health needs. The emphasis on bias and systemic oppression also leads to a narrative where every health disparity is viewed through the lens of discrimination, potentially overlooking other very important and well-documented contributing factors, such as genetic predispositions, environmental factors, personal lifestyle choices, lack of preventative health care, and delays in seeking medical help when significant symptoms do arise. By attributing disparities predominantly to systemic bias, there is a risk of simplifying complex health issues into binary social justice issues, which may not lead to effective or appropriate interventions. Dr. Caplan will discuss this further, as illustrated by the issue of maternal mortality gap between Black and white pregnant females. This is an area that has been carefully studied and well documented with a variety of causes, but racist healthcare workers is not one of them. Clearly, social determinants of health are significant and need to be addressed. But I strongly submit that with so much to learn in medical training, time is more appropriately spent by MDs learning anatomy, physiology, pharmacology, diagnosis and treatment of acute and chronic illness. Let's not forget that there are others available in the healthcare team that may more appropriately address these various social determinants of health, such as social workers, nutritionists, public health professionals, and many others. As we delve deeper into these matters, it is crucial to maintain a balanced view that considers both the potential benefits and the limitations of DEI in medicine. After all, not all issues raised by the narrow view of DEI in healthcare are detrimental. The goal should be to enhance our understanding of how social issues affect health without compromising the scientific rigor and individualized care that are paramount in medical care. What has the impact of DEI policies on medical practice been? It's on the practice. The implementation of DEI practices in healthcare settings is a multifaceted issue that significantly impacts medical practice. These policies aim to create more inclusive environments and address disparities in healthcare delivery, but they also introduce new challenges and ethical dilemmas. A notable example of DEI influence can be seen in the allocation protocols for COVID-19 treatments and vaccines. During the pandemic, certain states adopted guidelines that prioritize patients based on demographic criteria, such as race or ethnicity, under the guise of promoting equity. For instance, guidelines in some of these states prioritize racial minorities for COVID-19 treatments and vaccinations, arguing that these groups were disproportionately affected by the virus. A similar scheme of racial preference is now apparent in kidney transplantation, where unnecessary changes to the kidney transplant waitlist are placing Black patients with lower need ahead of non-Black patients with greater need. These decisions raise significant ethical questions. The insertion of racial and ethnic considerations into the treatment decisions challenges medicine's ethical principles, particularly the commitment to impartiality in medical care. Whereas medical ethics traditionally enhance the idea that individuals should be treated according to clinical urgency and individual need, the newly fashionable DEI ethical framework posits that treatment should be determined by demographic characteristics. These policies have brought to the fore concerns about the high potential for reverse discrimination and the erosion of public trust in medical institutions. By appearing to favor certain groups over others in life-saving medical decisions, there is a risk that these policies could undermine the foundational principle of equality in healthcare, where treatment should be based on need, not identity. It is essential for the medical community to engage in thoughtful and rigorous debates about the merits and drawbacks of these policies, ensuring that any implementation enhances the delivery of equitable and effective health care without compromising ethical standards or the quality of medical care. Unfortunately, to date, Students and medical professionals who question the DEI initiative have been afraid to speak out, afraid to discuss these matters due to the real fear of retaliation from those with positions of authority in our medical institutions. Now, let's look at specific DEI initiatives. As we delve into an analysis of specific DEI initiatives implemented within the healthcare system, it's crucial to critically assess their intended goals against the actual outcomes. This evaluation allows us to discern whether or not they mitigate disparities or trigger unintended consequences. One DEI initiative is patient-physician racial concordance. Patient-physician racial concordance is grounded in the belief that matching patients with doctors of the same race or ethnicity enhances communication, trust, and ultimately health outcomes. While some studies report improved patient satisfaction under such arrangements, the evidence indicates that concordance is not a solution for improving health outcomes. A recent comprehensive review of the literature has carefully documented that the literature overwhelmingly indicates that concordance is not associated with better care or better outcomes. Moreover, the few studies that assert otherwise are fraught with immense methodological issues that cast doubt on their conclusions. Do we really want to encourage the resegregation of healthcare without a proven definite benefit to health outcomes? What about recruitment and training strategies? In response to DEI objectives, many medical schools and healthcare organizations have revised their recruitment and training strategies to emphasize demographic diversity. While the diverse medical community is beneficial for numerous reasons, including promoting a broad range of perspectives and experiences, history demonstrates that a focus on demographics comes at the expense of focus on merit-based criteria. This approach not only challenges the principle of meritocracy, but also risks compromising the quality of medical education and healthcare delivery by prioritizing identity over competence. For example, strict testing standards have been dropped on the grounds that testing is racist. With the goal of increasing admissions to med school for those minorities previously underrepresented, 40 institutions have dropped the MCAT requirement. But studies show that low MCAT scores predict low performance in med school and a lesser likelihood of comprehending the courses that matter most to patient care. Furthermore, in order to allow more minority students to qualify for competitive residency programs, the medical licensing exam's first section, which has typically been relied upon by residency programs to select candidates, has been changed to a pass-fail system. What are the consequences of all this? Notably, a recent study observed that patients assigned to internists who scored highest on the American Board of Internal Medicine certification exams were less likely to die and less likely to be readmitted than patients assigned to doctors who scored lowest. Competency and excellence truly do matter. What are the broader social considerations of DEI in healthcare? The focus on identity and group characteristics within healthcare settings can have the unintended consequences of reinforcing divisions rather than bridging them. Policies that shift societal values in healthcare from a focus on individual merit and clinical excellence to group identity could lead to a perception that healthcare quality is secondary to social objectives and potentially erode trust in the healthcare system itself, as John alluded to. Trust is foundational in healthcare patients. Patients need to believe that decisions about their health are being made based on medical necessity and best practices, and not socio-political considerations. As a result, we are already heading to a situation where, for example, black patients will fear white doctors, and vice versa. This is a terrible situation. DEI also presents complex ethical challenges in healthcare. One of the central tenets of medical ethics is the principle of treating individuals with impartiality and according to their specific health needs. DEI initiatives that introduce considerations of race, gender, or other identity factors into treatment decisions can complicate this ethical mandate. For example, if DEI policies lead to prioritizing certain groups for treatment based on historical injustices, healthcare providers might find themselves navigating a moral quandary. We have previously mentioned two such examples, COVID-19 treatments and renal transplant priorities. This tension can lead to moral distress among healthcare professionals who may feel that they cannot always act in the best interests of their patients due to policy constraints. Then, there are the legal challenges. The implementation of DEI initiatives in healthcare also introduces a range of legal challenges. DEI initiatives often face legal scrutiny, particularly when they involve changes to hiring practices, admissions policies, or patient care protocols. Protocols that are perceived to prioritize identity over merit or medical need. The legal battles frequently hinge on the interpretation of civil rights laws and the Constitution. Legal challenges might argue DEI initiatives lead to reverse discrimination, creating a contentious environment that requires careful legal navigation. And I'm all for lawsuits. What about academic freedom and permissible discourse? The introduction of DEI principles into medical schools and healthcare institutions often comes with guidelines or on permissible discourse. This raises questions about academic freedom and the extent to which institutions can or should regulate the speech of students, faculty, and staff to promote a respectful and inclusive environment. While the intention behind such regulations is to prevent harassment and discrimination, it is often perceived as stifling open debate and the free exchange of ideas, which are crucial for academic and scientific progress. In some cases, discussions about DEI initiatives can become highly polarized. Such polarization can hinder constructive dialogue and lead to social tensions within educational and healthcare institutions. Managing these dynamics effectively requires a balance between fostering an inclusive environment and upholding the principles of free expression and academic inquiry. It means committed leadership from the top. Unfortunately, all too often these days, the top is part of the problem. As I conclude, our examination of DEI initiatives in healthcare is clear that on balance, these initiatives are doing more harm than good. Returning to a proper course requires the medical profession to first and foremost reaffirm our commitment to the core principles of medicine, scientific integrity, and the prioritization of individual patient care above all. Healthcare must remain a field driven by empirical evidence and a dedication to patient outcomes, not swayed unduly by shifting social or political currents. Looking forward, let us return to a system centered around excellence, a system where diversity is celebrated not only in demographics, but also in thought and approach. Thank you.
Yeah, I'd rather stand. I'm Martin Caplan. I'm a retired interventional cardiologist. I'm retired almost 5 years. On my last day, I gave up my scrubs, put on my street clothes, walked out, felt like I was Morgan Freeman leaving the Shawshank prison. And now I feel like I'm being dragged back in. Anyhow, I'm going to talk about the difference between black and white maternal mortality. There is a 2.5% or a 2.5 times increase in black maternal mortality compared to whites. But before we get into that, I just want to talk a little bit about how you can look at studies. And since was an interventional cardiologist, I'm going to talk a little bit about cardiology briefly. Way back, there was a study which showed that beta blockers after a heart attack, drugs like metoprolol, that you're all familiar with, I'm sure, reduced myocardial infarction by 50%. That was a relative risk reduction. When you look at the absolute numbers, it reduced it from 8% to 4%. So what was the real consequence? Especially when you think about the number of people that don't tolerate beta blockers very well. So there's relative risk and absolute risk. When you look at relative risk, it amplifies your findings, and you can play statistical games. Another issue was cardiac stents. There was a lot of publicity not too long ago that we were overdoing our cardiac stents, and they were done inappropriately. And there was a large study which purported that people that were treated with medicines rather than stenting did just as well as if they had had the stents. So all these evil cardiologists were putting equipment into people that they shouldn't have been. But if you look at the study, all the people that were screened for the study had cardiac catheterization. Of those screened, only 8% were entered into the double-blind study. Why? Because some of them, their cardiologists would look at them and go, oh, that looks awful. There's nobody that's not going to intervene on this patient. And others, they would say, you're not entering this patient in the study, that doesn't need anything done. So in the people that were entered into the study were a select group, only 8% of those screened. And initially, those treated medically did as well as those that got stents, but then there was crossover later on, and actually stenting deemed appropriate. The other part of that study that people don't talk about much is that the patients that were entered had chronic stable angina, which means it's been ongoing, they could walk a couple of blocks, and then they'd get their angina. Most often the patients that we would see had unstable angina, new symptoms, worsening symptoms, and the pathophysiology in an unstable patient is different than one in chronic stable. So now let's look at mortality statistics based on a national study from 2022, and it found that black versus white mortality related to pregnancy was 2.1 times white. Hispanic and Asians are actually lower than whites. So they looked at the groups and they compared different socioeconomic groups within each other. And they found at each level, if they compared upper economic blacks and whites, there was still an increased mortality among blacks. If they compared lower class whites and lower class blacks, blacks still had a worsening mortality. So they went through all this, and yes, there are issues with access to patient care, but if you've read any of the biographies of, or memoirs of J.D. Vance or Rob Henderson, who both came from basically an underclass white background, the social pathologies that they found were the same social pathologies I think that you would find in any underclass group, and having poor access to medical care. So why do we think there was an increased mortality among blacks? And a lot of this correlated with my experience. I mean, obviously I was not in a huge referral base seeing a group of pregnant women, but within the black population, there's higher amounts of hypertension, cardiomyopathy, and I'll go into that in a little more detail, pulmonary embolism, and kidney disease. So there's an entity called peripartum cardiomyopathy, in which we find in pregnant, either during pregnancy or immediately post-pregnancy, the women will have heart failure. And it's much more common in blacks than whites. And that correlates with my experience in practice. And it often seems to be more severe in blacks. Now, granted, this is anecdotal. Pulmonary embolism is more common in blacks than whites. Hypertension is more common, and kidney disease is more common. So as you look at older group of pregnancies, a lot of these factors come into play with black women. There may be a difference in cigarette smoking also. So, is this racism, systemic racism, or are there genetic differences? And there are genetic differences in populations. I'm an Ashkenazi Jew. We're at risk for things like Tay-Sachs. And there are other genetic variations depending on where your background lies. And so I think this attributes to a lot of the mortality. There's another study where in hospitals that were predominantly serving black patients, maternal mortality was increased, but that mortality level was the same for whites that were in the same hospitals. So you have to wonder about training and practice measures and ability to refer patients. I will say from my experience, if you think about a maternity ward with all these young women about to give birth, and all the young women and middle-aged women, men too, that were their nurses, caretakers, you can't imagine that any of these people who want nothing less than the best for each of these women. And so, yes, there's racism out there. When I think of my black friends, they've all experienced something that was racism. I've experienced anti-Semitism. I mean, you can't grow up in Philadelphia without running into some sort of dysphoric behavior. And I just don't think that systemic racism is the answer. The DEI has its foundations in Marxism. It's very similar to these old left-wing kind of confessional sessions and focusing on things that take you away from the individual is wrong. So when I was in practice, I told my office nurses, I had 3 main office nurses, they went from very good to excellent to absolutely superb. Treat every patient as if they were your favorite aunt or uncle and get them in. And don't protect me from my patients. So I think DEI is going the wrong direction, and we have to go back to treating people as individuals.
We do have time for questions, and one of the ones that I want to, it's weird to ask you to suppose what someone else would say, but if we had 2 African American doctors here, do you think they would share your assessment? Someone, let's say, who graduated from medical school a decade ago, has been practicing for 10 years. Do you think they would see, would assess this in the same way, or would they be amenable to opening the doors to medical education to people who didn't have a 3.8 and a certain competency in certain scientific courses of study?
What do you think, Mark?
I think they'd be more likely to disagree. I would say one thing about standardized testing. From my history, I was pretty much of a screw-up in high school. And when it came to standardized testing between the MCATs, parts 1, 2, 3 of the boards for medicine getting your licensure, I did really well in those tests. It actually surprised me. I was above the 90th percentile. So standardized tests give people a chance to show what they can do on their own. So there is a place for standardized tests. Colleges are going back to SATs because they predict how well people will do. But I think younger generations would be more likely to favor the systemic racism. You know, again, you have to think about the individual.
Yeah, younger people, it's in the culture. And with older patients, you know, I remember when I was applying and the Bakke decision came up. I don't know if you all know about the Bakke decision. That was Justice Powell, who lived in Richmond, made the compromising opinion on that. So he wanted, anybody ever read Heather McDonald's Diversity Delusion? It's a good book. Baki wanted to go to medical school. He sued, said he was white, and he was not allowed in because he was white. So it went to the Supreme Court, and that's when the affirmative action was. They said, I don't remember all the details, but you could. Race can't be the only factor, but you can take it into account. That was the compromise that Justice Powell unfortunately came up with, because there were two sides that split half and half in the Supreme Court. And that opened the Mack truck that everybody drove through since then. That was around 1970s, early 70s. And so we have had affirmative action in the older doctors, and you would say, how would older doctors feel? Well, I think that compromising on meritocracy, of course you want doctors to be empathetic. You want to have a holistic view of who you're admitting into medical training, right? You have to be kind and a good listener, but you also have to be really smart. There's so much to learn in medical school. I can't even begin to explain. And it only starts after you finish your training, because always new things are coming up. You have to have that mindset, that commitment to hard work endlessly. I always tell my wife, I feel like I'm a monk. I mean, I just have to constantly focus on that. It's only now, later in years, that I've looked more at politics. With, I have more time. I'm only working 3 days a week. And so you need that type of personalities, and it is reflected in scores on these standard tests, which have proven that they do better in training and in taking care of patients. As I said, there's a result, people die. And so doing away with meritocracy is a very slippery slope. I think that Justice Powell's compromising decision was horrible. And even the recent decision on affirmative action into medical schools left the door open, and they're doing end runs around with the current Chief Justice. And so, we have our work to do. I'm the president of the Richmond Jewish Alliance. We signed on and helped edit the amicus brief for the TJ Governor's School parents when they were suing, where they lowered the bar and said it was discrimination against Asians. Got to know them, very nice people, and it went through the court system. We dealt with 2 amicus briefs, and it recently lost at the Supreme Court. And I was very despondent, but I spoke to the lawyers, and they said, oh, perk up, we just have to keep doing more lawsuits, because I'm not exactly sure how that works, but it's not an easy path, and we have to remain diligent.
You've been on the radio with me a couple of times, and I'm going to take questions from the audience in just a second, but one of the times you were on with me, I went back to my office, and one of the rules I've learned the hard way is don't pick up the phone as soon as the show's over with, because you're going to it'll eat up another hour, and it's somebody who's mad with you. But I'm stupid. I picked up the phone after you had been on the air, and I had a guy, I think he was African American, I didn't ask, but he thought we were way over the top in our conversation on the radio, and one of the things he said that stuck with me, and it bothered me, was, you're too worried. The people who don't belong will wash out. They'll wash out of medical school. They will be dismissed by the administrator. The insurance companies, if they kill a bunch of people or there are a lot of lawsuits, they will not be able, of course, there's a consequence to that, right, for the patient, but that they won't be able to keep practicing.
All right, listen to this. First of all, they don't flunk them out, all right? They are, the top, so the leadership is committed to getting them through. There's whole programs of making them feel comfortable, people who don't belong there, right? And they take tests and they fail, but they don't flunk them out.
Get out, you have to really be egregious. It's a different subject, but the people coming into medicine have really changed. It's not the same where medicine was really a calling for us old guys, and we're old guys. And there's sort of this feeling of not being dedicated. There's a lot of reasons for that, perhaps. But you get these provocations where somebody doesn't do things right, and if you react to it, you're the bad guy.
Right, microaggression.
And so there's a lot of that in medicine. And any of these things could be interpreted as racist issues, depending on who is doing the complaints.
Well, of course, everyone's always assumed if you're a doctor, you're making good money, right? But it does appear that it's kind of turned into the Prada bag of professions, that you want to be able to claim that you got it, but then are you really dedicated? This is something that you feel strongly about. You want to constantly grow your knowledge. There's a TikTok. I know Ann McLean will freak out about this, but how many people still have TikTok on their phone despite the Chinese spying? I do. I don't think they're going to get anything that's worth anything off my TikTok, but there is a TikTok channel full of young doctors and nurses, and one of them is a young woman who says you can get into medical school, and she brags about having C's and D's and getting into medical school. And fortunately, there are people like me who go in and say, I don't think that's actually something to brag about, is getting in with those low grades. But that's I feel like it's counterculture for us to say that's not a positive. Being a doctor is not just about making good money and being able to, brag that you have achieved that. It's about the work you're going to do on the back end.
When I started medical school, the first day of class, we all looked at each other, and everybody had the same look on their face. These kids were really smart. Am I going to be able to make it here? Well, they don't flunk people out anymore. This was 1974 already. But am I going to be, can I get at least be in the top half of the class? I don't want to be a slug. And then there was genuine fear of not being competent, because there's so much to learn and experience, and the stakes were high.
All right, I see Will McGurn with his hand up. Will?
Question for you, doctors. Has there been any studies to show there's any connection between women who've had abortions and women who have trouble with childbirth?
Not that I'm aware of.
I'm not aware of that.
So I sort of have this assumption that the unconscious is unknown. So how do we know? And I assume that you were telling us that's going to be that implicit association test. And that's how they're going to tell us the extent and content of the biases in our unconsciousness that we otherwise wouldn't know. Is that it, or is there another method for knowing what's in the unconsciousness, which by definition is unknown?
I don't think my unconsciousness is any of their damn business. What I do is what counts.
So that's a methodological point. I got that. But as a methodological point, is that the only way that they think that they determine what's in the unconscious?
Well, I think the other avenue is they just assume you're racist.
Well, that's my point. But the point is, unconsciousness by definition is unknown. And they're trying to impose something. We know that you have something, materials in your consciousness that constitute what we're going to call bias. And I'm just trying to figure out, is the implicit association test the only method for doing that, or is that not even?
I don't know. As far as I know, they rely on that European study that says 68% of whites that took the test were proven racist. And then subsequently, there's a very heated argument. That's the arguments that went back and forth in the research psychology community. The person who started that, did the study, originally was from Harvard. She's as woke as they come. She's the head of the psychiatry program. There's a great article on that. I think you might have read that. It's got the cut article that goes into real detail. But even the people who are part of the study and are big proponents of this thing, even they admit it's totally unreliable. It's totally unpredictable. It's a waste. But the media picked up on this, because in the European study they just did the test on people, and 68%, they had one study, so give it racist, and then media ran with it, and then ever since, oh, well, it's proven. So I guess if you go into these biased forces, and I imagine some of you who are in corporate businesses have been parts of these, Elena, have you? But they just assume that you're racist, and some of them give the implicit assessment test. But it goes back, that was a major study, and remember I said how they do poor studies, and then they draw improper conclusions, and they exaggerate the conclusions. And then it gets into the popular culture, and so many conservative parents have woke kids these days, going to woke college.
You know, when you meet somebody, there's about a gazillion things that go through your head as a first impression. Race is only one of them. Their body posture, their look on their face, the way they speak, it's how you behave. And even if I found patients that I knew I felt uncomfortable with, then I went out of my way to be even more polite. And I think that's something that somehow they have to teach better. And, I mean, there are doctors that don't really know patients. And you always hear about surgeons, you know, that can barely talk to their patients.
Right.
I mean, that happened to me with a surgeon that was one of my buddies. Post-op, he walked in, go on. That's a surgical mentality for a lot of them.
It does seem like it's a catch-22, and I'll bring up two issues. One's a little dicey, I guess, but I work for the veterans, the Iraq-Afghanistan Veterans Association, and we raised a lot of money to come up with psychiatric care for vets who were contemplating suicide. So a lot of vets were very angry with us because we were perpetuating in their minds a negative stereotype about vets coming home from war and being broken. But then the vets who weren't broken, who really needed the help, couldn't get the help. And some of them had been exposed to certain medical needs that certain doctors wouldn't know to ask about. And then, you know, I've got a lot of friends who are gay, who don't want to go to a doctor, who can't address kind of the unique, some good things, some bad things, lifestyle issues associated with that. So how do you, if you want to be a good doctor, you really do want to be fair with everyone, you're not judging someone, are you allowed to ask those questions without getting yourself in trouble?
Well, the first thing I want to say is you have to understand, at least when we went to school, medical ethics was ingrained in us. So first of all, we're not, you know, I take care of eyes. Everything's under a microscope. But for me to think about these other peripheral matters, you know, so yeah, I've operated on people with HIV, and I have to, you know, we have to take certain precautions, let's say, and make sure that they're not immune compromised, you know, but there are two things. You want to look at the individual patient. We're so wrapped up. That's why it's hard. You know, the DEI stuff comes from sociology. It's not. It's amazing to me that the medical field has let itself be usurped by these idiots. We only want. We're concerned that we might make a mistake. You know, like I have a gazillion patients that I've operated on, and they all do well except the one or two that I can't sleep about, right? And that you worry about. That's the mentality of physicians. We worry. We're constantly being bombarded with new technologies and new treatments that we have to learn. And so that's one thing. The other is, you know, so you know, things like race and gender identities, you know, it's irrelevant. Now, but if you have a certain thing that somebody is an expert on, and they may be more expert because they have the same thing as you, then fine. But the bottom line is expertise. And you want to go to somebody who knows how to fix it, to cut it out, to treat it, you know. So you want to have a focus on meritocracy and on excellence and on individuals.
Right.
Add two things to that. In all my career, we did a lot of emergency angioplasties, heart attacks. It evolved to the point where we couldn't do much of anything when I was an intern and resident, to the point where we'd get a call and zip them off to the cath lab and put in a stent. In all the phone calls that I got from the ER, race was never mentioned. They said, we got a 45-year-old woman with an inferior infarct. I'll be right there. I didn't know what I was going to get when I got in there. The rescue squads never called us and told us what race anybody was or anything else. And another issue that was just brought up, let's say there's an issue with sarcoidosis. It's not a common disease, but it's more prevalent among blacks. But if the experts in treating sarcoidosis are white, then I think it's insulting to the black patient not to be sent to the expert who's there to treat their disease. And I think they would be insulted. Why are you sending me to this guy? It's just absurd.
And that's happening.
Yeah.
You got a question?
And another part of the DEI thing is, if you say you're not a racist, you're a racist. If you say, you have to admit you're a racist. If you don't admit you're a racist, you're a racist.
So, my understanding is in my wheelhouse is education, and the best predictor of what is going to happen here is to look at government schooling. What is big, because diversity, equity, and inclusion have been embedded in the state of Virginia for the last 10 years, but going back 15 years, is that if you can't simply be not racist. So my children can't, I taught my children to love everybody until they prove you not to, that we were taught that skin color does not matter, is that when that is now wrong, the melting pot is racist. You have to constantly be acknowledging race and then be seeking to destroy systemic racism, which means you must believe, and that's what they're teaching children. And it is what they're doing to children is oppress or oppressed. That is why the children are the way that they are. And so when you involve medical, it's also law schools. They got a lot of them got rid of the LSATs. Now they just have to take the GRE. That's UVA. Don't take the LSATs anymore. Is that the best predictor of how the world is, because this has been a long-term trend, is to just simply look at the children. And those are the ones that we consistently ignore when we have these conversations. But this is that situational ethics, moral relativity. There is no factual anything. I have a great article on John Dewey and Leon Trotsky, who in historical relativism that I stumbled upon. Nothing's real anymore. And so, you have to look at it as what has happened and then what the medical community, because it's far more frightening to think of people operating on people that didn't have to take tests.
Well, to that point, Dr. Swain said on Wednesday she thought perhaps DEI was receding with some of the evidence of late with the UNC getting rid of funding for some of those positions, University of Texas getting rid of funding for those positions. When you look at your peers and when you visit medical schools, would you agree with Dr. Swain, or they've got their fangs into you all and they're not letting go?
I don't believe that. I hear that, people are saying that, they're so entrenched. So I was talking with someone today that listening to William Jacobson speak. So he's head of the Legal Insurrections Foundation at Cornell, professor of law for many years, but has a great website and shows all the DEI things going on at all different colleges. He said no to that answer to your question, and he thought that it's so ingrained in the schools. You have these DEI offices everywhere. The faculty, the way it's set up, the faculty hires the new hires, and they gradually become 99% far left, and they run the show. And they teach the children, and they brainwash, and there's no diversity of thought. And so how do you fix that? How do you change it? And it's difficult. So the answer is, I disagree with what she said. He said the one solution he thought, and it sounded reasonable, is that the federal government has to do away, I don't know about private schools, but with funding. because they don't care if alumni, it hasn't phased them, alumni not giving money. But when they can't get money for their grants, and when they can't, it doesn't matter how much money Harvard has, because it's all tied up. To run the day-to-day operations, they would go under right away as soon as the federal government says something. And so, as exemplified by when Harvard kicked out military recruiters on campus, the federal government said, okay, you do what you want, you're not getting funding. They turned right around and they brought it back. So the bottom line is you got to turn Washington what color,
Elena?
I was in a great conversation a couple of weeks ago with the Lieutenant Governor's office about healthcare and bias in healthcare, or potential bias in healthcare. One of the things that was perceived reality, some of the ladies that we were talking with had to do with the amount of time that a physician spends with their patient, and seeing a disparity, whether that was race or socioeconomic based, but seeing a disparity in the amount of time and the level of care that they're giving the physician. I posit that might have to do with Medicare, Medicaid. I know you're not primary care physicians, but do you have thoughts on that? I mean, you do probably see a lot of Medicare.
From what I'm hearing is that primary care physicians don't have the time to spend with patients. They're not self-employed. They're part of the big companies like DCU or HCA or Bon Secours Mercy, and they're relegated to how much time they spend per patient. And they've got an enormous amount of paperwork and texting, messaging, and hassling with insurers. They don't run their own lives. So from what I'm hearing, it's difficult to get in to see a doctor, and they don't spend much time with you. And I don't think primary care doctors are particularly well trained. And when I started, I did primary care. I knew that the patients themselves were my employers. We had a 3-man group, and we were dependent on who came to see us. And we were also part of often in the same community, because Richmond at that point was pretty small. And we didn't want to irritate them, and a lot of them didn't want to irritate us. But I think primary care has been bad for everybody. And it's not necessarily a racist thing. I would imagine that under things like Medicaid, it's even worse. I don't know.
We'll go to the doctor, and sometimes, doctors, wait long, and the doctor might be not listening to you, or whatever it is. You're in the hospital, and you're waking up in the middle of the night, or things that can be very annoying, and people perceive that any way they want. But when and if you say, well, they did that to me because they're racist. I know that nurse, that white nurse, she's got it. When as far as the studies that have been looked at this stuff, they can't find anything like that. That's not a these are anecdotal stories. And what's happening is when we're saying and teaching people that they are racist against you and they are hurting you, that's making it's magnifying it. It's making their perceptions worse. They're afraid. Black patients are afraid to go to the White House. Just think where this trail could lead. We need to go back to the Martin Luther King philosophy, right? That's what you all here, I'm sure, believe in, right? Anything else is a dangerous dark path.
Is there a difference between your Medicare and your private insurance patients?
I treat everybody the same. Just ask Bert. Her son's been shadowing me. Just ask him. I talk too much when I'm in there. I socialize. So it doesn't matter. I don't care about the insurance. My staff does that. It's just the patient, and you want to take care of them. This is me. I can only speak for myself.
But another issue with that is that patient choice has been limited, because you sign up with an organization and they assign you to a primary care doctor.
Right.
Back in my old days as a primary care doc, if you did something the patient didn't like, they wouldn't come back. And, that happened to me. I once had a patient who said, "Doc, is this Cardigan making me get up at night to urinate?" And I said, "No, I don't think so." And he stopped it and got better. He was so mad he wouldn't come back and see me. So the next time a guy came in and said, Doc, you think this cardizem's making me get up at night to urinate? I said, yeah, it probably is. Why don't you stop it? He came back to me and said, Doc, you're a genius. And medicine, you know, your interactions with patients, medicine itself is always humbling. There's always something unexpected, and there's something always new or different. And I don't know that we're communicating that to some of the younger people.
And that's where meritocracy comes in, because it's the work ethic. That's the person you want who's going to stay with you.
All right.
And they're not responding to
We
authorities.
made an agreement that we'd be done at 1:15, so let me try to get one question over here, and we got 5 minutes total left.
Even though the governor has vetoed the bill, do you think medical schools will still be required, because it's required tied to federal funding? Or will students be able to opt out, and what sort of effect might that have on
That bill was vetoed, so it doesn't exist. But if there is, if the governor is a Democrat the next time around,
But could the individual school still require it, because it's tied to medical, or to the federal government requiring funding that they have this in their school?
this was SP. You talking about SB 35?
Yeah.
So SB 35 was for recertification of practicing doctors, which we had to get recertified. You have to have a certain amount of credit every 2 years, and they were going to mandate. So right now, so forever, we could go anywhere. I would take eye surgery things. I just need enough. I would take these courses. I'd travel all over, and you get a certain amount of credit for it, and then you just turn it in at the state, and that's it. They were going to have the Board of Medicine certify these bias training courses, and that's new, because the Board of Medicine would be in control of seeing who's going to teach it. And then you'd have to pay a lot of money, just like VI officers. People who are giving these training courses make a lot of money. But it's been quashed. I think the way it'll come back is if they stay glued down there and they try it and then run again. I might point out that at VCU, a good sign was that the Board of Visitors just voted down where they were going to mandate racial IQ kind of courses for everybody entering the school, and they kept that as individual choice, but it wasn't mandated that everybody has to take it.
It's already been, they've removed it now.
So don't be lulled into complacency with this election and the next election. We're not a political group, but it all comes back to who's making these decisions at our state capitol and in Washington. And I do want to be respectful. It's 1:13. You want one more question? Judy?
Hi, I'm Judy Watkins. I just want to say Dr. Lipstock's been my ophthalmologist for decades. He has treated me exactly the same whether I was on a different insurance, now I'm on Medicare. So thank you for being a great doctor.
Thank you.
Hey. We'll end on the endorsement. Thank you both for being here.